procedure for the videos. So let me know if everybody, when you guys are back.
Yeah, I'm still watching it. I'm watching the last one.
Oh, good, good, thanks.
So have everyone received the email invitation to the videos?
It sounds like they did.
All right.
Excellent. Okay, I'm going to get started, and Aiden, would you want to start the video again, or the recording?
It's started.
Okay, thanks. Okay, so we're back, and I wanted to just finish up the exam portion, and hopefully you received the video links to the Google Drive. That was why we had to get permission, but we sent it all out, so you should have been able to look at the videos. We'll talk about your questions after I go through the exams, and then we'll talk about your questions or if you have any insights into the video. Okay, so I'm going to go through this pretty quickly. In your Moodle folder, there's actually checkoffs, exam checkoffs. There's one for cardiovascular, there's one for sensory, there's one for neuromuscular, there's one for skin. And I put those together so that you do have some kind of intimate details about what the exams look like. You know, what's the observation part? What's the auscultation part? What's the palpation part? So I'm going to go generally through these slides, but you are going to have the option then of looking at just those PE checkoffs. And if I were doing this with my doctoral students, then I would be making sure that they knew every part of those checkoffs, because they are truly touching patients. So, okay, now we're finishing up this neuro assessment. Remember, it was 5 different sections. It was the mental emotional, it's the cranial nerve, it's motor, sensory, and reflexes. So we're at the sensory part, and I'll tell you what, most of the time I don't do a very detailed sensory exam. I usually just see if they have light touch, and that you always check for symmetry. Okay, so whenever you're doing anything with motor and sensory, always make sure that they can feel things in the same place on the opposite leg or the opposite arm or on the face, because you always want to make sure that you've got symmetry. The key to abnormal is the lack of symmetry or any changes that they might have. Now remember, sensory exam is actually what you're doing to them. The perceptions of pain, for example, are not what you're doing, but what they're feeling. So you cannot necessarily recreate their pain, but you could manipulate their hip or their leg and say, like, for example, on a straight leg raise, you can lift their leg up or they can lift it up and they'll say, oh, that means that gives me pain in my lumbar spine. So you can do that kind of pain, or you can palpate muscles to elicit pain, but you can't measure the pain and you can't describe the pain. You can always only say that tenderness occurs, or with raising of the straight leg raises, lumbar spine hurts. Okay. So again, pain and temperature is, they work on different tracks of the spinal cord, and that's kind of why I have this track in here. So pain and temperature are usually called the lateral spinal, they're actually the spinal thalamic tracks. Position sense is in the back there where their green columns are. And light touch is more on that, it's more anterior, a little bit behind the spinal thalamic tracts. And the lateral corticospinal tracts are actually motor tracts. Okay, so they're a little bit different. So again, just be conscious of the fact that you want symmetry, and if you find asymmetry, then that's a problem. Motor status, you want to grade the muscle strength and tone. You want to look at the muscle size. You want to see if there's any involuntary movements. So those are tics or tremors. I had a patient who came in, and she actually, her mother was my patient, and she ended up coming to me as the primary care provider. After her mother died, she decided she wanted me as her PCP. And what she said, you know, I have these shaky hands sometimes. And so we looked into it, and it was involuntary, the shaking of her upper extremities, and it was at rest. And the characteristics of shaking tremors at rest led me to a diagnosis of Parkinson's disease. And she does, in fact, have Parkinson's disease. She was been diagnosed. She sees the neurologist, and she's been put on carbidopa combination, and she's doing better. Remember, with Parkinson's disease, they also have an underlying depression with extreme, once they get into more progressive Parkinson's disease, they also get cognitive dysfunction. Okay, watch people for their gait pattern. This is something that you always see with strokes, multiple sclerosis. They have a wide base of support, so they walk kind of like with their legs spread apart because they have a balance issue. Stroke people usually drag a foot or a leg. Heel to toe is just balance. And I always have people at least raise up on their toes and raise up on their heel, just so I can see whether they can actually pull their feet up and their heels up, okay? And the Romberg is have them close their eyes. They can have their feet together, their arms by their sides, and just push them. And a positive Romberg is when they lose their balance. Okay, so I usually kind of hold on to them a little bit, or at least have my arms around them when I push them, just so if they do have a positive Romberg, that they don't fall. On the right-hand side is the way I grade motor. So to me, well, actually, those are actually reflexes on the right-hand side. So normal reflexes are 2, and stronger than that would be hyperactive or clonus. Rapid alternating movements is just finger to nose, and rapid hand and heel to shin. And again, you're looking for their ability to do things. Lagging would be a problem. You can see that in multiple sclerosis. They might not be able to move as quickly on things. Here's your grading of your muscle strength. Grading is 5 is strong. And so 5 is always my baseline. And say, for example, I get a 3, I always put it 3/5. So moves through full range of motion against gravity but is unable to take any added resistance. So that's a 3. If I pull on it, there's no resistance. I can just pull straight down on it. So knowing that 5 moves through full range of motion against gravity and takes maximum resistance, now I'm saying to whoever's reading my chart that they don't have any resistance, okay? But they can move it against gravity. Whenever you're doing muscle strength testing or sensory testing, the patient has to be cooperative, and you have to have them answering the questions. Otherwise, it's not valid. And then grading muscle tone. 0 is flaccid. And remember, flaccid is going to be related to lower motor neurons. and that's the peripheral nervous system. So if you injure that reflex arc, there's no reflex and the muscle tone goes away. Clonus, on the other hand, is usually seen in something like multiple sclerosis. It's high spasticity, and it's a upper motor neuron disease, okay? So that's kind of a little quick and dirty way to remember it. Here's your reflexes. I do reflexes every once in a while. I don't do it routinely on all my exams, but if I'm thinking that they have a radiculopathy, you know, they have cervical problems, lumbar problems in their lower extremities or something, then I will do biceps and triceps and brachioradialis on the upper extremities, and popliteal Achilles on the lower extremities. Babinski only means there's an interruption of the corticospinal tract, which means if you rub the bottom of their foot and their foot flares out, that's a positive, it's a Babinski that's present, and it means there's some interruption of that corticospinal tract, and that's abnormal. Adults should be flexing downward because they feel it and they almost want to pull away. Babinski is present until about 2 years of age. Okay, so some of the others, abdominal and cremasteric, I don't do them very often. I don't think they're very reliable. I do look at Brzezinski's and Koenig's, and I do those as a matter of looking for signs of meningeal irritation. So if I'm thinking that maybe somebody has meningitis, those would be positive. Straight leg raises, I already discussed, gives you some back pain. The Fallon and Tennille signs are for carpal tunnel, and usually if you do the Fallon, they'll feel some numbness and tingling, or they'll get some motor weakness, and that's very, very actually pretty diagnostic of carpal tunnel. So I'll send them, I'll give them either a little brace to wear at night at bedtime, and then maybe send them to an orthopedic doctor to release the release the tendon. Chopsticks is a really good sign, and it's one to look for hypocalcemia, and basically you're just kind of tapping the cheek and it quivers a little bit, okay? And then there's your reflexes again on the right-hand side. All right, and then I just put this in so that you have some idea of a neuropathy, a myopathy, and a neuromuscular junction problem with your reflexes and sensory involvement. All right, cardiovascular. So the first thing that you want to look at with the cardiovascular is just look at their necks. And on the right-hand lower side, you can see that that is really, that's a venous distension. So that's a sign of overload, of cardiac insufficiency. And if they're laying flat, if you're laying flat, you should see venous distension. But if you raise somebody up and you see that kind of a column on their jugular vein, that's failure. Okay, and this looks, and you can see this guy already has a scar on his chest, so he probably had heart surgery. But you can see that his raising the head of his bed doesn't decrease the column, which it should because of gravity. So that's something that's really important. And then we already talked about pulses, and I always like to percuss and palpate if I have somebody who tells me that they have heart palpitations, or they're feeling a rapid heartbeat or something like that. Then I'll palpate or percuss. Mostly I auscultate. And the auscultation is you're looking for the heart sounds at the aortic, pulmonic, the tricuspid area, and the mitral area. I suggest that if you've never heard murmurs, that you go in and you actually can Google murmurs, and you'll hear, you can say, let me hear an S3, let me hear an S4. Usually an S3, if you hear it, it's gonna go, it's kind of like it's an extra sound, and S3s, if they're present, are usually heart failure, okay? So I gave you some grading of murmurs. I have to tell you that I probably do not hear grade 1s and 2s myself because I'm not that skilled. But if you're in a cardiology clinic, you're going to hear all of them. But I can usually pick up a murmur, and I can usually determine if it's systolic or diastolic. And then, of course, I'm going to get an echocardiogram because I want to know what's going on with the valves. And then I usually do like a referral to cardiology. EKG basics, that's a whole course in itself, and maybe if Dr. Steinman or Tackett want to work on that or want you to know that, I'll be happy to teach it. It would take me about probably 6 to 8 hours to do all of the dysrhythmias and teach you how to look at an EKG and at least get the basics of it. But I gave you some just EKG is electrical activity of the heart. The P wave shows atrial activity. The QRS shows ventricular activity, which is depolarization in both instances. And T waves are recovery of repolarization of the ventricle. And just I put the leads on there. There's limb leads and what we call precordial leads. Those are along the chest. So you have to just ask if you want that, and we could do some work on it. Remember, I was telling you about the anesthesiologist who called me and asked me about the patient. And if you look at this lower screen, that's atrial fibrillation, and that means it's going irregular. It's an irregular contraction and depolarization, and that if it's slow and taken care of, it's not too bad. The problem is when that rate gets really fast, there's not enough filling time in that irregular rhythm, and they get fatigued and they get short of breath, and their blood pressures fall and they get into trouble. The other problem with atrial fibrillation is if it's chronic atrial fibrillation, the atria is not contracting. And if the atria doesn't contract, it holds on to some of the blood in that atria because it's not getting out, and it pools. And they can throw a clot out of that pooling blood and actually have a stroke. So anybody who's on atrial fibrillation has to be anticoagulated. Most of my patients are on the new anticoagulation medications. And I still have some on Coumadin, and some of them are okay just on aspirin. But you really need to know what's going on and how long they've had that atrial fibrillation if they have it. So EKGs, hearts are the common diagnosing heart issues. Stress tests, chest x-rays, echocardiograms, those are all diagnostic tests. And then medical, we talked about myocardial infarction, and that's something that we could look for with troponins. Heart failure, you want to look for a BNP. That's B as in boy, N as in nerd, and P as in Peter. Okay, BNP. And if it's over 500, then they're in heart failure. And then endocarditis is often seen in IV drug abusers.
Dr. Davis, could I ask a question?
Sure.
On all of these assessments, the reflexes, I mean, there's a lot of things that you're going over. How much of this or what will be on an exam? Because I'm not sure how to be preparing myself as I'm listening. Okay,
so you know what? For the PEP exam, Dr. Steinman knows a whole lot more about that than I do. But I would, like I gave you some pretest questions that are mostly about physical assessment, and they're pretty basic. So I would never expect you to say, oh, okay, this is atrial fibrillation. What I would expect that you could pick up that it's an irregular beat and it's fast.
Okay, so in other words, not the PEP exam, but your exam.
Yeah, no, I would just say, if I were asking things, you can't diagnose off a 12-lead EKG anyway, right? But what you're going to see in your office is you're going to feel or hear a very rapid, irregular heartbeat. that is abnormal. So for you in your office, you have to just be able to say, this is abnormal. I don't know what it is, because I wouldn't even know what it is unless I did an EKG. Do you see what I say? You see what I'm saying? But I know in my exam that it's abnormal, and then I have to go further. So if you see or hear that it's abnormal, then you need to refer them back to their PCP. And if you think that they're not compensating well, you send them to the emergency room.
Okay. But for questions on the exam after the weekend class, what types of questions or things are you expecting us to know?
Just pretty simple stuff.
Okay.
Okay. Like I went through like a central seventh versus a peripheral seventh. I want you to kind of know that.
Okay.
So if I kind of dwelled on something, you might want to take a look at it. Okay.
Uh-huh.
Okay. And then let's go to respiratory. And to me, inspection, remember I told you I watched just listening. I just listened to them and watched them. And if they can't tell me their story without taking lots of breaths, then they're in trouble. Okay. And that could be anxiety for you. It could be anxiety in my office, but that's the differential diagnosis. Is it anxiety, or is it they're in heart failure? Did they get beat up and have broken ribs, and that causes that, shortness of breath for them. So you always want to think about what's the cause of it. And anytime you have any abnormal retractions of the interspaces, like they're retracting when they breathe, just send them to the emergency room. That's an emergency. Okay. But watch their patterns of breathing. You want it regular, and you want it under 20 breaths a minute. And then this is a great one, areas of tenderness. So a lot of people come in and they say, I have chest pain. And I'm like, oh, okay, when did it start? How often? Blah, blah, blah. Going through my patterns of like, okay, is this cardiac chest pain? But a lot of times I say, so if you touch it, does it hurt? And if they say yes to me, then it's not cardiac. If I can reproduce chest pain, then it's probably a costochondritis. It's an inflammation of those muscles or the cartilage of their chest. That's an important differential in your physical exam for chest pain. That's the difference between sending them to the emergency room and saying, oh, I think that might be because you've been coughing too much, or, you've irritated the interspaces. All right. Anytime you can, if they have a cough or whatever, I really want you to think about auscultation. Okay. And I'm going to go down there to those adventitious sounds. Crackles sound like plastic wrap, or those little bubbles. Okay, because what it is it's fluid in the air spaces, and you can, on inspiration and expiration, you can actually hear the little crackles. Okay, wheezes are pretty, and they usually are scattered and in a lot of different places. You see that in asthmatics a lot. Crackles you see in heart failure. Rhonchi are those coarse sounds that, and sometimes if they cough, they actually get rid of the rhonchi. And rhonchi are usually sputum or mucus in their big bronchial trees. And a lot of times you can have them cough and it'll go away. Or if they expectorate with the cough, that'll go away. But even so, if rhonchi is there, something else is going on. And remember, that's where you think about pneumonia, you think about asthma, you think about heart failure. Okay, common problems, just anatomically, you want to look for barrel chest. Those are the smokers. Kyphoscoliosis are people that have, basically a scoliosis, and so their spine is going to look different. And then any tenderness that you can palpate is either inflammation or muscle strain. Breath sounds, we already talked about all of those. I got them in there, okay? And what are your diagnoses? Pneumonia, COPD, pleurisy hurts. Asthma and bronchitis is usually related. Coughers get bronchitis, COPDers get bronchitis, and I will always treat one of my COPDers if I think they have bronchitis, because I don't want them to get an exacerbation. Your x-rays are for pneumonia, tumors, fractures, pleural effusions, and foreign bodies, okay, for chest x-rays. A lot of times I can just pick up the pneumonia. Here's the pneumonia right here on the right-hand side. I can usually pick up the pneumonia just because I can't hear good breath sounds in that area. So I have a heightened index of suspicion just because of my auscultation. All right. All right. I think Dr. Tackett told me about, you didn't do too much on abdominal and GI. So first of all, I do not do any bowel sounds because to me, bowel sounds are kind of useless. There's two ways to know the bowel is working. One is if they can pass gas, and the second one is if they have a bowel movement. People have all kinds of gurgles and stuff like that in their bowels, and so I really stopped listening because I don't think that it's diagnostic of anything. I put it in here just so you know that there is something about bowel sounds. If you're going to try to listen to bowel sounds, always auscultate first. Don't palpate first because then you've messed it all up. Okay? I always look for scars. I look for pulsations. And I'll tell you what I do listen for, though. I do listen for abdominal aortic aneurysms, and I have found those. And that is like, talk about bounding abdominal aortic sounds. So if you have a stethoscope, lay down in your bed and put your stethoscope right above your belly button, okay, and press down, and you should be able to hear your abdominal aorta, or you can at least palpate it. All right. I have a patient who has a 4-centimeter abdominal aneurysm right now, and he's sick with cancer. So I can't, I know he needs to have this repaired because it's widening, but the vascular surgeons won't touch him because of his cancer. So what we have him doing right now, he's in chemotherapy and radiation. And if he can beat the cancer and get that under control, then the vascular surgeon will do his surgery for his aneurysm. It's crazy. It's crazy out there. Okay, so sounds are dullness. Dullness is over something solid. So the liver should be dull, the spleen should be dull, but the stomach has air in it, so you're going to hear tympany there. So you're going to have almost like a little drum sound there. Tumors are solid, so they're going to be dull, all right? Oh, GU and reproductive, I have to tell you, I do a lot of digital rectal exams on my men. I'm looking for prostate enlargement, and basically they're going to come in and say, I can't pee, or I'm peeing too much, or I'm not getting enough out, my stream is weak, and then I'll do a digital rectal exam and figure out what's going on. The other thing with the males is they might say, oh, I have exudate coming out of my penis. Then you definitely want to know what they've been doing sexually, and if they use condoms and things. And depending upon your practices, you might be in a high-risk group of people. The military, I've been in the military, so I know that there's, a woman in every port for some of the sailors, and I've seen them in the emergency room with a lot of venereal diseases or a lot of sexually transmitted diseases. So again, you need to talk about that with them and where they've been and what they do. And it's two things. One is protection against disease, HIV included, and then the second one is pregnancy prevention. Okay, so I just kind of put some things in there for you. Breast cancer for the women, prostate disease for the men. Urinary tract infections are very high in females. They're low in men. So if I have a guy with a urinary tract infection, then I worry about him because it takes a while for the bugs to go up the urethra in a male. So then I think about I think about STDs. Sexual preferences are very important. Sexual activity, the number of partners they have. Impotence is very common, particularly in patients who have diabetes, they're taking beta blockers, aging men, alcohol use. So they will have impotence, and we talk about it, and sometimes we put them on Cialis or Viagra and see how things go, and then they will get a GU consult. Kidney stones are they're buggers. They hurt. They're really painful, and it takes a while for them to pass it. They usually need a CT scan to at least find out where they are. Toradol, which is ketorolac, it's a NSAID, is wonderful. It really helps kidney stone pain much better than Dilaudid or morphine or fentanyl. Okay, bladder issues. A lot of times women have bladder issues. And again, that's a lot about their dripping, they're prolapsing, those kinds of things. They need to go to their OB doctor or GYN doctor. All right, integumentary. Just look at their skin, and for you in your practice, you want to look for stuff that would be related to injuring themselves, like cutting and cigarette burns, abuse patterns, those kinds of things. So that's one thing that I would really keep an eye on for you guys. Anything that looks suspicious on their skin, bruises. How did you get that bruise? I always ask people if I look at them and they have bruises on their arms, I'm like, well, tell me how you got that bruise. But that's not necessarily the reason they came in. Do you understand? But I'm going to ask them anyway because I see it and I want to know where that bruise came from. Women, I always ask them if they're in a safe environment. Do they have a partner that's good to them? Are they afraid of their partner? Do they stay with a partner because they're threatened? So those are the kinds of things that I ask. Lesions, if you see something that you don't like, a black nevi or something, just make sure they go back to their PCP so that it can be biopsied or they can get a referral to dermatology. All right. And then, like I said, these are kind of some areas of concern: self-inflicted patterns of abuse, rashes, and then any nevi or skin cancers. Okay. And remember, for melanoma, it's A, B, C, D. It's they're asymmetrical. B is that they have ill-defined borders. C is their colors are changing on the inside. It looks discolored. D is diameter. They're usually about the size maybe of an eraser. So you want to get them taken care of right away, because remember, melanoma is a systemic cancer. It's not just a skin cancer. All right, clinical pearls. Remember the role of stress. Okay, cortisol is released in that fight or flight mechanism, and if you have a chronic fight or flight mechanism, then you're constantly releasing cortisol. People get diabetes from that. They have asthma from that. Their blood sugars are elevated constantly. They get cancer. There's a lot of association with stress and chronic stress. Okay, just remember, differentiating normal from abnormal. If you know what normal is supposed to be, then when you find an abnormal, that's when you get concerned and you refer or tell them to go back to their PCP. Okay. And that's what I tell my doctoral students when they start out. You're not going to know the diagnosis, but you do know whether it's a normal finding or an abnormal finding. The D's with dementia, or the D's for me, are dementia, depression, delirium, and drugs. Okay, so always remember those 4 Ds. Cardiac output equals heart rate times stroke volume. That's kind of where I was going with that atrial fibrillation with rapid ventricular response. If you are going to increase, or if your heart rate, wait, hold on, let me start again. If your cardiac output goes down, your body is going to respond to that by increasing its heart rate, okay? The stroke volume is going to go down if you're dehydrated, if you're bleeding, if your contraction of your heart is not strong enough, And that in turn, so that equation is really important. So if that heart rate goes up, and Randy's heart rate was starting to go up because his blood pressure was going down. So in order to keep his cardiac output, he had to start to increase his heart rate, okay? What is hypertension versus hypotension? We talked about that with Randy. Dehydration is big. Self-inflicted wounds, look for them. Drug effects, interactions, and contraindications, make sure you know those. And especially know them when you are prescribing your psychotropics, because you have to look at the rest of the drugs they're on, and usually they're on a lot. So differentiating social pathology from organic pathology. So if I don't know what's going on with them, I have to look for the organic reason why they're sick. And then once I've ruled out everything, then I can say maybe they're just, having Munchausen's syndrome or something. Okay, but I can't go to Munchausen's first. Behavioral change, is it acute or is it a chronic change? If it's acute, something's going on, a bacteria or sepsis or something, an injury. If it's chronic, it's been going on over time. Evaluation after an intervention, and we talked about that. That was the test of a medication, or a test over time would be, let's see what happens with it, or the test of the medication is take the med, and if it makes you feel better, then that was good. New onset of a problem, again, that's that organic versus psychological. So it's important to kind of think that through. Laboratory studies, I know that Randy went through them. My go-to lab study is usually a comprehensive metabolic panel, because I get lights there. So I get everything in the basic lights, but I get calcium, albumin, protein, and liver studies if I get the comprehensive. And so most of the time my insurance is going to pay for the comprehensive. And I would suggest if you're going to do labs that you do a comprehensive, because then you get your liver studies and your calcium. Okay. Thyroid, first start out with a TSH. Remember that if the TSH is high, that means you don't have enough thyroid hormone. It's opposite. If it's low, that means they're hyperthyroid. They have too much thyroid hormone. Okay, either way, they need to be treated. Complete blood count, we talked about that. In a complete blood count, you're going to get the white blood cell count and the red cell count, the platelets, all right? And that's good. Liver profile, you can do a liver profile independently of the comprehensive metabolic panel, but usually I just look at it through my comprehensive metabolic panel. I will get hepatitis screens if I think that I need to do that. And that Hep C is now treatable in most cases. Hep A usually goes away by itself. And hepatitis B is usually related to, needles, sticks, IV drug use. But anybody who's in the healthcare field needs to be vaccinated against it. And then cardiac profile, I already talked about troponin, CK, CKMB, LDH. We don't use LDH at all anymore. Urine, I like urine. I like to see what's going on with their urine, because I can see if there's a urinary tract infection with the culture. Drug screens are important, because if they're lying to you about using drugs, their drugs aren't going to be in their urine. But if they're taking them and they're not telling you they're taking them, then you'll see those as well. Usually what I do is I pretty much test them up front, or I tell them I'm gonna get a drug screen on you, a urine drug screen. And if you don't want that, then I'm suspicious. Okay. Pregnancy, always with women who are childbearing age, you need to do pregnancy tests before you start them on antipsychotic medications, because they're tetragenic. So you can actually cause damage to the fetus. And that's not a good thing, okay? Because that's a legal problem. Wound cultures, I culture all the time. And then remember I was talking to you about those, the sensitive but non-specific. There's your ANA, sed-rate, C-reactive protein. Cancer markers are difficult to get through. You're probably not going to be able to get them through. I have trouble sometimes. Those are like CEA. So if the oncologists are following the level of cancer, they can tell by the cancer hormone release or something, and it's called a CEA. Endocrine studies, you need those. Those are the TSHs. Sometimes I do FSHs, which is follicle stimulating hormone for menopause. What else in labs that I do? Serum pregnancy is different from a urine pregnancy. There was something else I was going to say, and I forget what it is. I'll think of it. Diagnostics, we kind of already went through a lot of this. Already we know EMGs are electromyographic. So that's usually if you suspect there's nerve injury to a muscle. You want to get the nerve conduction studies, and anytime you have muscle weakness. Abdominal series basically is just kind of taking a look at what's going on, if there's air in the abdomen. But if I have abdominal pain, a diffuse abdominal pain, basically what I'll do is I'll get a CT scan with and without contrast of the abdomen and pelvis. That's going to tell me a whole lot more than just a plain x-ray of the abdomen. If you're looking for anything in the brain, usually you want to do with and without contrast. You always have to take patients off metformin or glucophage a couple days before you get a CT scan with contrast, because it can wreak havoc with the kidneys and liver. MRIs give you a much brighter picture, a real good look at tissue. And I do a lot of MRIs on backs and shoulders, and then I'm prepping them to send them to an orthopedic doctor. Okay. All right. Going through this fast. If you have questions, we'll give you my email and just text me or email me, whatever. Okay, Heather is another one of my favorite patients, okay? So Heather is a 36-year-old Asian female. She has 2 children, ages 8 and 3. She works full-time in a bank where she has a supervisory responsibility. She has a history of thyroid cancer and surgical hypothyroidism and hypoparathyroidism, all right? Remember, she doesn't have a thyroid at all. And the hypothyroid, the little parathyroid glands are embedded on the thyroid. So if you take the thyroid out completely, you also take the parathyroids, all right? She also has a history of migraines, and those are treated successfully with tramadol. She's using the, it's supposed to be NuvaRing, sorry, for birth control. It's NUVA. Since her last child, she has increased mood swings and describes panic attacks at work and when she is at home alone with her kids. She's also saying that she's depressed. She is being seen by an endocrinologist who manages her thyroid problem, okay? So how are we going to approach her? So she's coming to you because what? She's depressed and she's having panic attacks, all right? So she's one of my patients. I try to make her go to the psychologist or go to counseling, but she doesn't always follow through with that. She would rather come and talk to me. So every time I see her in the waiting room, I'm like, uh-oh, things aren't good at home. So anyway, what do you already know about her? Call it out.
She could be prone for depression because of the hypothyroidism.
Good question. Perfect question. Yep. So that's good. All right.
How old is her last child?
Her last child is 3. And for some reason, a lot of these symptoms started after her last child. Okay.
So she also looks like she is high functioning, right? Like she's a supervisor. She has 2 kids. She's been dealing with these things for 3 years.
Yes, yes, she is, and she wants to stay a high functioning, and she needs them. They need the money. You know what I mean? She works because they need 2 incomes, but she's having trouble at work, okay, because of her mood swings. And there's even another part of the problem, but she's having some trouble just kind of getting through the day. But the tramadol is working for her migraines, and I give her maybe 30 tramadols, and she won't use 30 in a month, and usually it's like every 3 months. Okay, but the panic attacks are really getting her at work.
And are the panic attacks, can she determine anything that associated with the onset? Is there something precipitates them? Are they coming out of the blue?
Yeah, that's a good question. And see, that's the psychologist in you, but she gets herself worked up, and then then she gets into that panic mode. But we haven't really determined really why she gets into the panic attack mode. Okay. Okay, so you got some.
Tramadol might not help the panic.
Right, but remember, she doesn't use them that often, and I tried to see, I have her keeping a journal, so the migraines are not, and the tramadol did not track together, okay? So, do you see what I'm saying? That the panic attacks are usually different, and they're usually at work, okay? And she gets it when she's home by herself with the kids, when her husband's not around. She gets overwhelmed.
But it's all postpartum, you said.
It's post, yeah.
Symptoms.
Yeah, this has happened after she.
Is it postpartum depression?
It could be, but remember now it's 3 years.
Oh, okay, I see.
You see what I'm saying? So,
and how long ago did she have her thyroid removed?
Good question. Probably, I think it was before her baby, her 3-year-old. Okay. Now that's good. Remember, she doesn't have her thyroid. So she has no parathyroid either. Okay.
When did she start the NuvaRing and when did she start the migraines?
The NuvaRing has, she's been on it for a while. And actually, I have to tell you that she's not using it anymore, but she was. And that's the only reason why I started her on an SSRI, because she was on it.
What is she taking for her thyroid function?
Good question. So what she's taking is thyroxine. Okay. And she has been on varying doses of her thyroxine, or Synthroid. We'll call it Synthroid, right? And she sees an endocrinologist, and the endocrinologist started messing around with her Synthroid, and so that puts her in a spin when that happens. So she's very interesting. Okay. So what information do you want? What else do you want? So we have to think about labs here.
What amount of stress is she under at work since she had her last child?
She's under a tremendous amount. She has a supervisory responsibility, so she's in charge of the tellers.
Okay. Is she using any drugs?
No, she's pretty straightforward. She doesn't use drugs, and she would tell me that. All right. So, what medications should be on? You asked about the thyroid deficiencies, right? So she's on Synthroid, and I think her dose is 112 micrograms right now. And we've kind of said to the endocrinologist, don't mess around with it anymore. Just leave her on 112 until we get some other things straightened out. But here's the thing. What about hypoparathyroidism? What do we need to know about hypoparathyroidism? What labs are important?
But I thought that was taken care of with the surgery.
No. Remember, you need the parathyroid to regulate your calcium and phos.
Oh.
Okay, so when her calcium goes low, her phos goes up. What was the sign that we talked about? Chopsticks, right? So she can actually test her calcium level by herself just by tapping on her cheek. And if she gets sensation, she knows her calcium is too low. Okay, all right, well, let's go to the next slide for her. So what we know is that she's para 2, gravida 2. She works full time in a stressful job. History of migraines treated pretty successfully with tramadol. And she has recent onset of depression, anxiety, and panic attacks. She has a surgical hypothyroidism and a surgical hypoparathyroidism. Oh, here's her meds. So she's on her Synthroid. She's on calcitrol, which is a hormone, remember, calcium carbonate. And she was taking Tums 4 to 5 times a day because it gives her calcium. But we just changed her over to Oscal because she's tired of the Tums is making her sick in her stomach. So she does tramadol 50 milligrams with onset of her migraine. It usually helps. She usually doesn't have to take 2. And the NuvaRing, which is 3 weeks off and 1 week, or 3 weeks on and 1 week off. But she stopped taking that. So her vital signs are good. Okay, so here's some questions that I want you to think about. What are the symptoms of hypothyroid disease? What medications are needed to manage the disease? What are the symptoms of hypoparathyroidism? And what lab tests are necessary to determine if thyroid function is normal? All right, so these are things that, first of all, before you even say she's depressed or she's crazy with panic attacks, you need to understand her thyroid, right? Okay, so the answer to the first thing, hypothyroid, is fatigue, increased sensitivity to cold, constipation, dry skin, weight gain, muscle aches, elevated cholesterol, thinning hair, decreased heart rate, and depression, okay? So she has several of those. She's tired. Her skin is dry, but she's actually losing weight, and mostly that's because of her anxiety. She does have elevated cholesterol, and her heart rate is normal, but she does have depression. Okay, so we talked about thyroid replacement, Synthroid, levothyroxine, and Armour. Armour is more of a natural thyroid replacement, okay? What are the symptoms of hypoparathyroidism? Okay, twitching or spasms of muscles in the legs, feet, abdomen, or face, fatigue, patchy hair loss, dry and coarse skin, brittle nails, depression, or anxiety. Okay. What do we need to put her on? We need to have her on oral calcium, which she's on, right? Vitamin D, because we need calcium and vitamin D. Nat Para is something for parathyroid disease, but I haven't used that very often, and I haven't seen it used even by the endocrinologist. And then calcitonin, which she's on. So those 4 things are, at least the 3, oral calcium, the vitamin D, and the calcitonin are 3 that you want to put them on for the parathyroid disease, okay? And then what labs are necessary to determine if her thyroid function is normal? Okay, we're going to look at TSH. If she's hypothyroid, what would her TSH be, high or low?
Hi.
Hi.
Good, yes. And her T3 and T4, what would they be? They could either be normal or low, okay? Because she doesn't have enough thyroid, and T3s and T4s, that's actually the thyroid hormone itself. Okay, why do I want a comprehensive metabolic panel on her? The reason is because I'm going to see the calcium. All right. And then MAG, I want to do MAG on her just because I want to make sure that her MAG levels are okay. And her phos, if her calcium is low, her phos is going to be high. Okay. They're inverse. So you want to keep them both at the normal range. All right. So I think there's some embedded questions in here now that we can have you answer. Oh, okay. Let me just do this. This was her exam, and it was pretty good. So list 3 differential diagnosis, and how will you treat this patient? How will this patient be treated by his PCP, her PCP? Okay, here's your differentials: migraine, hypothyroid, hypoparathyroid, hypocalcemia, depression, anxiety, panic attacks. And then these are the things that we did. And then actually I do keep her on the tramadol, and I've talked to a neurologist and an endocrinologist about it, and they're okay with it. Now, I put her on 0.5 milligram of Xanax, and I'm asking you, is this okay?
As a psychologist, I would probably try some coping skills first.
Right. Okay. That's good. Why do you think I put her on the Xanax?
So she could make it through the day at work and be successful there. However, she's going to become dependent on it. And
Right.
then we have a problem.
Okay. Now, and that's perfect. That's great. And so I started her on a little Xanax, small dose, because and she actually takes half of the 0.5. Okay. But the reason why I did that is because I want to make sure in her labs, before I give her an SSRI, I want to make sure that she's not pregnant. Okay. And even the Xanax is marginal, but I also want her to go to counseling. Okay. And that was kind of, I can get her a little bit through the day with the Xanax. She doesn't take it very often. Then I actually started her on fluoxetine. And she just told me in her last visit that she stopped taking the fluoxetine. So she's kind of complex, and she's very interesting and needy. So, and
Oxetine, because it's activating.
right, but it also is good for her anxiety.
I understand, but it's an activating medication. So why did you choose this one instead of another one?
She's been on others, and they didn't work.
I see.
Okay, so she didn't want to go on anything that was putting her down. And we talked about that. But the fluoxetine actually helped her pretty well. And she stopped taking the Xanax for a few months. What happened in the meantime was she developed seizures. Yeah. And so she's very complex in many ways. And she's the parathyroid, the parathyroid problem influences her a lot. And her labs, and then her hormone levels. So anyway, she's a work in progress, just so you know. But so she's not really taking her Xanax anymore. She stopped taking her fluoxetine. She still has her panic attacks. But she went on an FMLA for about 3 months, so she was not working, and she went off all of her medications. And now she's back working, and now all of her symptoms are starting again.
I'm curious about what happened. What caused her seizures?
She has a sister who has a history of seizure disorders as well. So I'm not real sure why her seizures started, but the neurologist is pretty sharp, and we looked at all of her medications. And then we got the endocrinologist involved as well. And he does not think that any of the medications that she was taking started her seizures. Some of them are actually almost absence type seizures, and they always occur at work.
Psychogenic?
I don't know. It's very interesting. We have her up on she's on Keppra now, so she's even up on higher doses, and she had a breakthrough seizure on a higher dose of Keppra. So again, remember that we have to look at organic versus psychological. Her MRIs are perfect. Her MRI of her brain is perfectly normal. So we've done all that.
Can they do a video seizure study on her? Because that helps differentiate between the psychosomatic seizures.
Right. Well, and that's the next thing. But she needs to go back, and that's what I'm trying to get the neurologist to do is do the video, that, or even do continuous EEG monitoring for a couple days.
Are you doing that on Big Island, or there's on Honolulu? Is that Hawaii Pacific Neuroscience? They're a pretty good team too.
Well, we have to send everybody to pretty much Honolulu. So we're on the Big Island, so we don't really have that capability here. So she needs to do that. So that she's kind of a work in progress, but I wanted to bring it up because of her depression, anxiety, and her panic attacks. So, we kind of worked it out. When she was on the FMLA, she could get off everything. And as soon as she went back to work, it all started all over again.
Is there any contraindication for giving her an anticonvulsant for the migraines?
Well, here's the thing that I want to talk to the neurologist about is maybe instead of keeping up her Keppra, to maybe put her on Lamictal and see if the Lamictal and the Keppra combination, if he agrees to that, will help kind of mitigate her anxiety, bring her down. Now that I know that she wasn't being truthful to me in terms of the way she was taking her meds and what she was doing with the meds. And that wasn't until last week or 2 weeks ago that I found that out. Mm. So part of it is unraveling her story, and part of it is wondering what is motivating some of it. Do you understand? So I need a psychologist. I need one of you guys to come to me in my clinic. But anyway, that's kind of the next step is kind of to see if we can use a combination of anticonvulsants and maybe a Lamictal, And I told when she's not at work, she has a good day. So we've also talked about vocational changes, and she doesn't go to her counselor on a regular basis either. So she's sometimes non-compliant.
And you're thinking the Lamictal because of the antidepressant effects?
Yes, also, yeah. It would maybe do a combination.
Yeah.
So anyway, she's very fascinating, and I keep an eye on her also. So she'll come by. Sometimes she just stops in and sees what's going on so I can talk to her. All right, here's 4 questions that I want you to answer. All right. And then we'll take a break.
Someone have a cat on their speaker?
Oh, can you see her? Can you see my cat?
No, I could hear the purring.
She wants a treat, so she's gonna sit on me. All right. You're not supposed to be purring.
How did you want us to answer these questions? Just say it out loud, or?
Is there polling? Is Aiden there? you have any polling?
Doctor, you mentioned that you want them to say them out loud to you.
Oh, they
Have you-
can unless you need polling results. Do you need polling results?
I think polling is just for attendance, I think.
Yeah.
Okay. So why is that pregnancy test important?
Because of the SSRIs.
Exactly. And what's the problem?
We don't want to give her any medication that could cause a injury to the fetus.
Correct. So it's got like a C classification. Okay. All right. Question 2. What's a normal range for magnesium?
I profess my ignorance on this.
Okay. I'm going to give you a very simple way to learn it.
2.5 to something.
It's 1.7 to 2.2.
Okay.
Okay. So what you want to know about mag, you want to keep in your head number just 2. Okay. All right. Question 3. What's the normal range for phosphorus?
2.7 to 4.6.
Correct. Okay. And so when you look at mag and you look at phos, you want mag to be around 2, you want phos to be around 3. Okay. This is how I teach my undergraduates. Just like round it up and get a number in your head so that you can go a little bit lower or a little bit higher on that number. Okay. Question 4, why would her calcium levels be low? Sorry. Why would her calcium levels be low? Because it should be because and basically it's the calcium phos interaction. Okay. Because what's going to happen is she's not going to have her calcium, and then the phos is going to be going up. All right. And so remember that you want to do, you can either, the Chosvik's sign is very, very good. You can do it on the face, or you can actually do it on the wrist. And that's just a really quick thinking. Now, let's go back to her seizures for a minute. Okay. So her seizures started about August, maybe June they started. Initially, we thought that her seizures started because she had a low calcium level. And so the endocrinologist thought that's why she had it. But in reality, her calcium level at the time of her seizure was actually normal. So it wasn't a hypocalcemia issue.
Yeah, it sounds like that psychogenic non-epileptic seizures. That's what it kind of sounds like.
Well, but she does have a family history, and she does use tramadol and not some other. It's very low, but still, she does have an underlying potential, so to speak.
Well, and the other thing that so I don't want to put her on any other medication at this point, but
what about placebo medication? They can be effective as well without having the same.
That's why I really want to look at that Lamictal combination with the neurologist. So we're kind of in the process of, she has an appointment with the neurologist like in 2 weeks. And so, yeah.
But doesn't the Lamictal have some pretty significant side effects? If that's, if we're not treating something that's organic, if it's psychogenic, is it worth the risk?
Well, we have to find out, because she does have seizures, and
yeah,
like I
seizures
said,
are a pretty significant side effect.
so we have to make sure that they're not psychogenic seizures. But here's the other thing that happened. In November, she went off the deep end because she decided to go off her hormones with her NuvaRing, right? The endocrinologist was decreasing her thyroid, her synthroid, because she thought her TSH was too low. And then she was on her Keppra, and then she was at work, and it was like the perfect storm. So that's pretty much when she went on her FMLA, but she stopped everything kind of at the same time.
So maybe that triggered the seizures.
well, no, she had seizures before that, but then she went off of everything because she said, I don't want to be sick. So
Yeah.
she didn't take things, but she wasn't telling me that she wasn't taking her fluoxetine either. So she did not, it wasn't until 2 weeks ago that I actually found out that she was not taking her fluoxetine.
There's no history of head injury or falls recently?
No, she doesn't have any fall or head injuries background. So anyway, she's just she's an interesting young lady. I think part of it is stress. I think part of it is truly some organic thing going on with her brain. We know that it's not a tumor, or we know that. We also know that she's got parathyroid disease problems, which can really wreak havoc sometimes.
Is she in, sorry, you might have said this, but is she in psychotherapy?
She goes only kind of occasionally.
Oh, I see. So not really doing.
No, she's not on. And that's what I keep saying. Are you going? And then she says, yes. But then next time I say, well, how many times have you seen your therapist? And she'll go, oh, well, I was really busy, so I didn't go. So a lot of her, she's not being a good patient, and that's a terrible thing to say. Do you know what I mean? Not saying that in a bad way, because I really
and smart. I think sometimes I don't think I'm a good patient either. So she wants to be functional, and so she's trying to do her own things when.
Correct.
Yeah, but she wants to be functional. She just doesn't want to be functional at work.
Yeah, I don't know, but she hasn't been honest with me, and that's kind of what we're confronting now, is the fact that she's been changing things, and then she comes in and she's in a panic because, I had a seizure, but she didn't tell me that she was changing things around. Do you know what I'm saying? That's why I'm saying.
Sorry.
So we're working on trust, and we're working on honesty, and we're working on, let's get therapy. And the other thing is, I'm really, really trying to talk to her about why she does not want to go to work. And then she says that she gets so anxious at work and that she can't think straight. And so she will drink caffeine. She loves caffeinated beverages. She's almost addicted to those, which is not helping her seizures. It's not helping her anxiety with all the caffeine. So anyway.
And she's Asian, so she has a lower tolerance probably.
Right.
What about discrimination at work or something like that?
No. Because
not in Hawaii.
Hawaii is pretty diverse, and he works with lots of other multicultural, everybody in Hawaii is Hawaiian, Filipino, Chinese, Japanese, Portuguese, or some combination thereof.
A bit borderline.
Yeah. So, so you're giving me some insights into, some of her behaviors.
This is more psychotherapy, but I'm curious if she wanted the baby, the most recent baby, because all of this kind of ties around 3 years ago, and also stay-at-home mom possibility.
Correct. But then she says when she's at home alone without her kids, and here's another thing. Her husband has a job that's connected to, it's a state job, but it's connected to roads and transportation in some way, okay? So there are times that he gets called out because if it's raining and there's a mudslide, or there's there's something going on with the roads, he may be gone for all day, including the night. You see, so, and she talks about not being able to cope when he's not there. And then she tells me that he does everything for her. So there's a lot of dynamics going on with them. That's why I really want her to go and continue with therapy, but she's very reluctant to continue doing that.
Any family or peers, friends, anybody close by to help her?
Yeah, no, she has a strong family connection. Her mom and her dad. Her sister is disabled, the one with the seizures. And the other thing that her seizures, now sometimes she does describe them as clonic tonic, but a lot of times they are almost absence type seizures, that she kind of blinks out, like at work. She stops talking or she stops counting her money. And then she says, oh, the other tellers will say, are you there? Are you there? Are you okay? So, but she remembers those things. Is
this all self-report, or do you have any other reports?
They're all self-reports. But she's been into the emergency room a couple times so that her fellow workers have called the ambulance on her several times.
Medical records?
Yes, we have all the medical records.
Oh, I see. So you do have some objective measures.
Yeah, but I mean, what is an objective measure? You go into an emergency room, you're not seizing anymore.
No, but did she ever do a sleep study or an EEG or anything?
Well, the EEGs are one of the things that I want to get done. Okay. So that's something that I have to, you have to take this all with a grain of salt. We live in rural Hawaii. There's two neurologists here, and there's one the endocrinologists come from Honolulu. If I want to get sleep studies, there's one person who can do those. So, yeah.
Because somebody before said it all happened in the last 3 years, but the reported seizures are only reported.
They're only the last 9 months.
Yeah.
So,
but
anyway.
It can also be an anxiety attack,
Yes, exactly. So, what I did next is I just kind of I put in some different. Let me thank you for your input, because I think she's a good case. I did have my student psychologist and I and her have a powwow about. That's what I'm saying. We have to work on our trust and our honesty, and getting the plan together for the future. But as far as all the medications, we checked everything out with the neurologist and also the endocrinologist. So
I have a question before we move on. How much of the physical assessment as psychologists would we want to do with our clients?
Well, here's the thing that I would say. If you think that you are going to prescribe something, then you better know that they have good lungs and they have good hearts. They're not hyperthyroid. You've done, a thyroid exam and you've done some labs. Okay. As far as, musculoskeletal, I mean, you can document quickly that, they've got good motor strength. You can document cranial nerves, but cranial nerves are not going to change unless there's an injury of some sort, usually, or a virus. So I don't even do a lot of cranial nerve testing unless I'm working with somebody who just had a CVA, or I think that they might have the migraines might be related to some other kind of vascular problem. You know what I mean? So I would just say that pretty much baseline is, know what their heart function is and their lung function and their kidney function and their liver function, for sure. And their thyroid. I would document a thyroid exam also. Okay, and know their blood pressure, like I said, All right?
Yes, thank you.
You're welcome. So anyway, this is just kind of a little overview of some of the things that you might see. And so I just kind of put just some slides together with each one of them. there's one for bipolar. Let me just put this out. I find that neurologists do not do Keppra and Dilantin levels. In fact, I've been told by patients that the neurologist said, "Hey, would you tell her to get a Dilantin level?"
Hello.
Right?
Hi, how are you?
You want to put yourself on mute?
Good, we're doing good.
All right. Anyway, lithium is important, and it has a problem with changing QT intervals and things like that. So you need to monitor lithium levels. Okay.
It will be hard if you're not attached to a hospital or something. If you have
You find out what's
Well, no. The only thing you do is if you can make arrangements with the lab, a clinical lab, outpatient lab, and then just send them for it.
Yeah.
Okay.
More complicated.
Right, but if you're prescribing it, you better be able to check it.
Yeah.
Then you can't prescribe it if you're not checking it. Absolutely. Is my point, right? So I actually monitor all my lithium levels and my Keppra levels, my Dilantin levels, so that I know what's going on with them. So in fact, for Heather, I make sure that I know that her Keppra level is therapeutic or not therapeutic. So then I can go back and say, well, it wasn't because the Keppra level was low that she had the seizure. Do you see what I'm saying?
Yeah, of course.
Yeah. So anyway, I just want to make sure that if you're going to do some medications, then you need to monitor them. Okay. And so anyway, I just put some things in here for make sure that they never stop their medication without telling you, which is one of the reasons why I also think that Heather got into trouble, because she stopped taking her fluoxetine and she didn't taper it. Okay, for depression, make sure that you're thinking about those herbals again, St. John's wort. There's, conflicting evidence about it being useful in depression. It's dangerous with HIV meds, and it interferes with heart disease, depression, seizures, cancer, and rejection meds. Make sure also that you're thinking of serotonin. Serotonin syndrome, if you're using some of the serotonins.
How does St. John's wort interfere with HIV?
Because it has a little bit of serotonin.
Oh, I see.
Okay, so it could possibly increase the serotonin level. Okay. And then anxiety. So just remember that, I did give her a little bit of Xanax. It does take the edge off of her in some ways, but there's tolerance and addiction issues. And I'm aware of that. I'm aware of that with her. We talk about it every time she comes. Remember, beta blockers, they decrease symptoms of anxiety. Sometimes if the heart is racing, they put them on a beta blocker. The hyperthyroid patients also are on beta blockers also. Okay. And then ADHD, that's another good one for drug screening, because the medications are so street oriented, and a lot of times there's going to be there's no evidence of it in their drug screen because they're selling it.
How is it in Hawaii with the need of neuropsych testing to be able to prescribe stimulants? Or in other states?
I'm not sure. I could prescribe, but here's my philosophy. With some of the psych disorders or the mental health disorders, I really want a diagnosis. I can manage them, but I'm not I'm not a provider, you know. I'm not a trained psychiatrist or psychologist. So for me, I really like to have them actually diagnosed. And so if I think that they have ADHD or bipolar, I like send them to a psychiatrist for diagnosing.
So for the ADHD usually should technically be diagnosed by a neuropsychologist with testing.
Yeah.
You're not allowed to prescribe without neuropsych assessment at all.
Well, I don't prescribe those.
Yeah, but I thought it might be different from state to state.
Yeah,
Yeah.
I think it differs from state to state, and we don't have a lot of availability for it as well. We have a lot of neuropsychologists wanting to do the testing because they don't have time for it.
Which state are you in? Also Hawaii? I mean, where are you?
No, I'm currently in Georgia, Alabama. I work for the VA though, so it's a little different for us.
Oh,
Right.
I see.
Yeah, you can pretty much do whatever.
Most states don't require neuro testing, and like I do some neuro testing. I'm not a neuropsychologist, but I can do ADHD testing. But yeah, they can go to any psychiatrist or any MD and just get a script for it.
Correct.
That's also state dependent. And where are you at?
I'm in Connecticut, but I've been in Pennsylvania, Florida, and Mississippi and Nebraska, and it was similar in all of those places.
Right. And we don't have a neuropsych requirement in Hawaii.
Yeah, I know the VA, I could do neuropsych assessments for ADHD. I'm not a neuropsychologist either, but the VA doesn't pay me to do it. They don't set aside time for me to do it. And the psychiatrists usually won't prescribe it. So most of the time we just refer them out to the community. But I think community psychiatrists are more willing to.
A lot of third-party insurances also won't pay for extensive testing for ADHD diagnosis because they consider the ability to diagnose that based on a simple mental health assessment being medically fine. So a lot of insurances won't pay for extensive testing for ADHD.
They also don't pay like the normal 8 hours? Well, 6 hours?
Well, as a neuropsychologist, I would not consider 6 hours to be sufficient if you're really doing a comprehensive neuropsychological evaluation, even for ADHD, because there's so many other things that look like ADHD that aren't ADHD. But I'm in California as well, and they don't have those kind of requirements in California. You're not required to get a neuropsych before you can get prescribed medication.
Yeah, we're getting into politics here.
Yeah.
Oh, you know, but that's something that you're gonna learn to do. Like, you know, as a nurse practitioner, I worked in different states, and I have to know the regulations for each of the states that I work in. You know, like you asked me before, I can prescribe opioids, but I can't prescribe, you know, buprenorphine or methadone. So, I mean, I have to know what I'm able to do under my scope of practice, under my law, my state law. And as prescribers, you're going to have to know that, because every state, you can see that out of the 5 or 6 states so far that are allowing prescribing by psychologists, they're all a little different. There's no one size fits all. So you're going to have to be very, very cognizant of what it is that you can do. And for me, as a nurse practitioner, and especially in primary care, I don't have the skills to diagnose psychiatric problems. And so I send them out because I want to make sure I have a diagnosis. And most of the time I allow the psychiatrist to do the prescribing, because we don't have psychologists prescribing here in Hawaii yet. So I would prefer that. There are a few of my patients who I do prescribe some of their medications, but there are very few. You know, like if they're bipolar or they have schizoaffective or those kinds of things, I really let the psychiatrist handle those, but I monitor it. Like I said, I'm monitoring their lithium levels. I monitor Depakote because the psychiatrists are not monitoring it. I monitor their liver function because I know the psychiatrists are not monitoring it, right? I check QT intervals. So you have to be kind of, following up. You can't say, so I can't say, oh, well, they're diagnosing and prescribing, but I know they're not following up. So that it falls back on me. But you have to know your laws.
There's another common prescription medication for ADHD, guanfacine, which is a high blood pressure medicine, but it's a non-stimulant medication. So used a lot for people who have cardiovascular risk.
Oh, nice.
They don't want to prescribe stimulant medication to.
So it's 12:30. Well, it's 12:30 my time, so it's 1:30 Pacific time, right? Is that right? I don't know. I'm so sweet. It's 2:30.
It's 2:30 in California.
4 hours to go technically, I think.
You have what?
Just for me, it's much later.
Yeah, so you only have a half hour left, right? If this is supposed to be 9 to 3 for you?
Doctor, it usually go like up to like 3:30, 3:40. So I mean, it's up to you whether you want to give a break or want to continue.
Well, if you guys want to continue, we can, or take a break. That's fine. I just have one small study here, and then we can do more discussion if you want.
Let's continue and get over with it by 3 o'clock.
3 o'clock.
Sounds good.
Okay, let's do it. All right, so here's another one. This one is a little different. She's a 32-year-old woman who presents with a laceration to the knee after she tripped on the curb this evening, which was approximately 1 hour ago. EMT stated she was disoriented at the scene. Patient admits to drinking 2 40s and smoking about $40 of crack this evening. She admits to using IV drugs in the past, has a history of bipolar disease and endocarditis. Patient has a 5/5 strength in the lower extremities bilaterally. She has full range of motion and equal sensation. So what else is important related to her chief complaint and HPI? So this is basically what you're seeing. You're the behavioral health expert that's called to the emergency room to see this patient at midnight.
So does she have any medication for the bipolar? Is she currently taking it? And what else, if anything else, has she taken?
Meds, okay. Do you want to know what kind of IV drug she's used in the past?
Yes. Also her family history.
Okay.
Also, she hit her head. She's disoriented at the scene.
Oh, that's good. So did she hit her head? She has a little bit of disorientation. What do you want to know anything about her knee, or might be a good idea to just kind of take a look at that?
Are you suggesting maybe abuse or assault?
I don't know. That's why I'm asking. What are you saying?
Well, I'm not sure if I'm taking a look at her knee. I'm not sure that'd be my scope of practice. I mean, I would, if it's lacerated, I'd probably call a medic to come and suture it or whatever they need to do. But
okay, but you have to at least say that it's there. You can't ignore it.
Oh yeah.
Okay. And she's disoriented. And the good thing is that she has 5/5 strength in her lower extremities bilaterally. So what does that mean?
Both legs.
Yep. She tripped. So you want to make sure that both sides work. Why did she trip?
Why did the hospital release her if she was so heavily intoxicated and on drugs?
No, she hasn't been released.
Oh, she's still there.
Yeah, you're coming in to check her.
This is her history of, this is her chief complaint and her HPI.
Okay, thank you.
I probably want to do like the Perla thing, or make sure that there's no difficulty with her eyes.
Yeah. And what about a cage on
Mhm.
her? You might want to think about, you know, I mean, how much alcohol does she drink on a usual basis? And she's smoking about $40 of crack this evening. And what kind of crack is she using?
Yeah, and where's she at? So how much does $40 get you?
Exactly. Okay. So, I mean, just kind of, it's a silly little case, but the idea is what's missing and what do you know about the story? So HPI is about creating a story so that you have the information when you go back and say, oh, I get this. And I know what the gaps are. All right. So, all right. So to me, having a lot of experience in emergency rooms and trauma, I think that she might be somebody who is a little bit belligerent, maybe with some slurred speech. Perhaps she's cursing at everyone who comes into the room or throwing things. But what you want to do is you have to kind of work through that, right? And you want to document the HENT exam. Somebody talked about level of consciousness because she may have hit her head, which is good, especially if it's unwitnessed. You don't know why that slurred speech is occurring. So document that she's awake and alert, she follows commands, but is belligerent, okay? Her speech is slurred, but is it comprehensible? That's good. Her hair is disheveled maybe. Is there any ecchymosis in her facial area, facial lacerations, facial tenderness? You did get the perla. Are the pupils dilated? Extraocular movements are intact. Is there any thyroid enlargement? Are there any masses? Okay, so make sure that you've looked at her head and her neck well. And we started with the cranial nerves there, right? Pupils equal reactive to light and accommodate. At least you're looking at ocular motor 3. And you're looking at EOM, so what cranial nerves are those? Extraocular movements are 3, 4, and 6, because those are the conjugate disconjugate gaze, right? 3 goes up and down, 4 goes medially, and 6 goes laterally. So 3 is ocular motor, 4 is trochlear, and 6 is abducens, right? So you want to make sure she can follow commands. All right, so you want to document that neuromuscular exam. She fell, and you don't know if she hit her back or she hit her head, but at least at the time of the that you saw her, she's got good muscle strength. 5/5 means what? 5 is the baseline strength, and she is 5, so she can use her muscles against resistance. Okay. What about her integumentary exam? So you want to make sure that you know that her skin is cool and dry or warm and dry. What if it would be cold and clammy? What would that indicate to you?
Possible shock?
Correct. Absolutely. And then you would also want to make sure that you looked at her vital signs as well, right? Okay, so laceration to the right knee is 2 centimeters with gravel embedded deep into the wound. So I'm not sure. I think it's the VA person. You're right. I would probably get one of my CNAs or somebody in the ER to clean up that wound and get it cleaned out, and then ultimately put some sutures in if it needs it. It's 2 centimeters, right? But there's no evidence of bruising of her upper or lower extremities, so that's good, and no evidence of needle or track marks. So that's part of that skin exam.
Give her a tetanus shot too.
That's right. So let me ask you something. What's a Tdap?
Was it tetanus, diphtheria,
And
pertussis?
pertussis, right. And who gets those?
Should be everybody.
Tdap. So that's the adult vaccination. You only need to get it once, right? It's a CDC recommendation for adults. We get it when we're kids, but it's not called Tdap. It's DAPT or Tdap something. But it's got the diphtheria and pertussis with the tetanus when we're little. So now you need to have it at least once as an adult, and then you can go back to having your regular tetanus shots of every 10 years. But you need at least one with diphtheria and pertussis, okay? But in the emergency room, they're not giving that. They're going to give tetanus, right? Okay, do we need anything to be documented on her cardiovascular exam?
Probably.
Like what? Tell me.
Probably her pulse rate.
Okay, we want her heart rate and
Blood pressure.
blood pressure. Okay, now she tripped. Do we know why she tripped?
Which was probably drunk and high.
Yeah, that's one possible, right?
Well, and that's probably true.
Um,
Don't know what she was taking.
Yeah, we have to make sure she's not hypotensive.
She
Correct.
could have had a cardio event from the crack.
Yeah, exactly. So I would now, I mean, this is like the ultimate like crazy case, right? But I'm just trying to point out to you is that you need to look at everything. And she's got slurred speech. She tripped. You don't know why she tripped. She is drinking. You don't know what she was taking for her crack. So I would definitely document a cardiovascular exam on her, okay? I would probably maybe even do an EKG just to make sure. But if my auscultation, I didn't hear anything, you know, like I wasn't hearing any abnormal S1 or S2, I didn't hear any murmurs, and her rate was normal range, I probably wouldn't do an EKG, but that's something that you want to keep in mind. All right, and you need her blood pressure, right? Heart rate and blood pressure. Okay, what about respiratory? What do you want to do for respiratory?
Listen to her lung sounds.
Yeah, well, at least get a respiratory rate, right? And I always like to listen to lungs just to make sure I'm not missing anything, okay? If she was an IV drug user in the past, what might you think about?
Well, probably things like HIV or other communicable diseases.
Right. Well, the other thing is endocarditis, all right, which is another reason why it might be important to do an EKG on her, okay? Okay, so respiratory, you can listen to her lungs, make sure she's got a good, even respiratory rate. She's not impaired at all. And because of her alcohol use, what's going to happen with respiratory rate and alcohol use, potentially?
Becomes depressed.
Correct. So you want to make sure that she is breathing okay. You know, you have something on standby in case she does stop breathing. You don't know, again, what crack she actually took. So you might want to think about any anecdote, which might be a narcotic anecdote, you know, like a naloxone or something like that. What drugs do you want to know on her? Well, I mean labs, sorry.
All of them?
Yeah.
All right.
I mean, at least a UA drug screen, pregnancy tests, CBC,
UA.
metabolic.
Well, how long will it take to get the UA back? Would you want to do like a blood test since she's in the hospital, ER still?
Oh, the UA will come back pretty quickly in the
Okay.
Yeah. The UA and the drug screen are going to come back very quickly. And the reason why is because they do drug screens all the time on drunk people, trauma patients, belligerent patients, so the UA and drug screen are going to come back pretty good, fast. What was the other one that you said? Like a metabolic panel. Somebody said something. Okay.
Metabolic panel, I'd want to know electrolytes and all that fun stuff.
Okay, so what I want you to think about is, I want you to think about the difference in your state, whatever you order. So think about what it is. Is it a basic? A basic, usually you get your electrolytes, which are potassium, sodium, chloride. Typically you'll get a creatinine, a BUN, and you might get a glucose. Okay, so you want a basic is like a 6, or plus the glucose is usually a 7 different parts of that. The comprehensive, remember, is usually like 12. So what you're going to see with the comprehensive is you're going to end up with the same electrolytes. You're going to get a creatinine and a BUN. What does creatinine and BUN tell you?
Kidney functioning.
Okay.
Kidneys.
Okay, but creatinine is a better gauge of function than BUN, right? Would you treat somebody's kidney failure with the BUN alone? No.
Not on a single lab test, no.
Right, well, but remember that the BUN is blood urea nitrogen, and that's going to go up for a lot of reasons. It could just be because there's muscle injury and she fell. Okay, so you want to make sure that you have a creatinine so you know what's going on with their kidneys, and also the estimated GFR to look at kidneys. And when you have that comprehensive metabolic panel, you're going to get the estimated GFR and creatinine and BUN. Okay?
Question, is a hospital really going to do a comprehensive if someone comes in
Yes.
in this condition and has no insurance?
Yes.
I think those are the facts of life now.
No, in a hospital, they are going to do it.
Okay.
Okay? Because she's basically a trauma patient.
Yeah, they're going to do it. Someone's going to pay for it, even if it's us.
Well, yeah, it's going to get done because she's basically a trauma patient. And so they have to look for reasons why she fell. I mean, and you can't just say, remember, oh, well, she's drunk. Well, she might be, but remember, she's got a history of IV drug abuse. She's taken medications in the past. So she's a little bit on the cusp of somebody who needs to be taken care of, okay? What I want you to understand is what the difference is between a basic and a comprehensive metabolic panel. What do you want? If you want liver function tests, which you need for her because she's been drinking a lot of, she had 2 40s, so she's drinking beer. So obviously she does have a tolerance. So you want to see what her LFTs look like, right?
Would it
an IV drug user isn't a hepatitis and something that you might want to think about, but you're not going to get a hepatitis profile on her, but you certainly want to look at her liver function test. What is about her ALT and AST? Okay.
Would measuring her glucose even matter? I mean, she's been drinking beer, so her glucose is going to be high anyways.
Right. It sure is, but you know that it's a non-fasting glucose. Okay. So what happens if she has a non-fasting glucose of 500 or 600? Even after drinking beer, a non-fasting glucose of 500 or 600 is not good, right? You would think maybe 250, 300. Okay. So it doesn't. It's still gonna be drawn with that, and it's still gonna give you information. But you're not gonna treat her for diabetes if she's got a fasting blood sugar of 250 and she just drank.
I don't know how it might work in other areas. I mean, would they be doing periodic mental status exams to make sure that her mental status is improving, that's not remaining the same? Because then I mean, there was no sign. There may have been no sign of a head injury, but you could have had like a closed head injury that doesn't present, and if her mental status is deteriorating,
Correct.
and that
Yeah, that's great. That's why I said, what diagnostic test would you order on her?
And you would probably get imaging, right?
Correct.
well, I mean, you may not. I don't know. They may not order imaging right away if there's no sign of head injury, because then it'd be, kind of wasting really expensive diagnostic tests. But I
Yeah, it
mean,
might
if
be
her,
kind of hard to get a CT through without a bruise at least, or
yeah, but if her mental status is not improving over time, or if it's deteriorating,
Right.
because she's not going to be on drugs while she's in the ED, so it should be improving over time.
Correct. You're right. You're
But
right.
would they order imaging on the knee?
I probably, they probably would get an X-ray of her knee. Yes. It's a pretty deep laceration. It's already got gravel in it, so they might want to look for foreign bodies. So now remember, as she's presenting kind of as a trauma, she's presenting as a trauma patient. And so they're going to do a lot more things with her than they would if, you got somebody who's pretty together and said, hey, I tripped on the curb and I fell, but I didn't hit my head. And she's coherent and, she can tell you what's going on. This one is she's got slurred speech. She tripped. You don't know the whole story. She's coming in by herself. Okay. So you're right. I would make sure that we did something with her head, and I would maybe watch her. But I would think that a typical ER visit for a patient like this, they would do a CT scan on her brain. And what would you find if you had a closed brain injury? What would you find potentially if you just had a concussion on a CT scan without contrast?
I mean, my knowledge base isn't that extensive in terms of what the imaging would look like for a concussion versus like subdural or epidural bleeding.
Okay. All right. So let's just walk through it because I want you to understand it. So if you have a non-contrast CT, you're only looking for basic structural changes. Okay. You're not looking for tissue changes. That's what the CT with contrast is going to give you. Okay. So in an ER, typically they'll just do a quick CT scan without contrast. And
looking for a brain bleed.
They're going to look for hematomas because the shifting of an epidural or a subdural is going to show the difference. You're going to be able to see that blood. You're going to see traces of blood in subarachnoid space, okay, or in the ventricles if there's bleeding. All right. So that's all you're going to see structural changes. But that's important stuff because if she does have an epidural or a subdural, she may need to have it removed at some point, right? But you have data. If it's a concussion, and this is going back to neuroscience, remember that you've got the neurotransmitters that are released, aspartate, and those neurotransmitters that get released when you have an injury that is chemical, but it's not going to show anything on a CT scan because it's a chemical injury. But the patient will have a brief loss of consciousness, but it's a closed head injury concussion, and it doesn't show anything. So you're right about serial changes. And then, first of all, you've documented, wait a minute, we don't have anything like brain or blood in that brain. Okay, for sure, we know that. So now we're going to watch her after we've done a baseline CT scan on her, right? Rather than have her deteriorate on you. It's probably better proactive to see if there's anything bleeding. All right?
Mm-hmm.
Okay, so, and part of this is that you're probably not going to do all of this. You're a psychologist, and you're probably not going to be in an emergency room, but hopefully you'll be reading reports. And the idea of looking at reports is that you have knowledge of what those reports are telling you. And that's why I'm saying, yes, get a CT scan or get the comprehensive metabolic panel. And yes, if the glucose is high, you can say, well, this is not a fasting glucose. But if it's way high, that's a problem. And they're certainly going to send that report to me as a PCP and say, you got to take care of this sugar. Does that make sense? So I just want you to be aware of things that might happen. Are there any other diagnostic tests that you want to do? So I would do the CT of the brain without contrast. That way you don't have to worry about if they're taking metformin or any other diabetic medications because you're not using any contrast. You have a good cardiovascular exam. You're thinking about maybe doing an EKG on her just because you would like to see what's going on. If she does have some endocarditis history. And you're going to get the knee x-ray. That's a good idea. You got a UA, you have a drug screen, you have a comprehensive metabolic panel. How about a CBC or a WBC? Do you want to look at her blood counts at all?
I would. We really don't know the status of just how she's doing overall, if she's still using IV drugs and we're just not seeing the track marks. There could be infection or something there. Right,
exactly. So I would definitely just do it. And so a lot of times when you're in an emergency room doing something with trauma, you usually get both comprehensive and a WBC. So good thinking. Anything else you want to do with her? You're doing great.
Now that's just cruel.
A little bit, yes.
That's Waikiki at sunset.
We have snow.
I can show you dirty snow in Connecticut if you'd like it.
It's at the Sheraton Waikiki. There's a very cute little bar that's right there on the ocean, and they have great sunsets.
Yeah, I used to surf out there quite a bit. I kind of miss it.
Yeah. So, you know where the Sheraton Waikiki is then. Yeah.
Oh, yeah.
All right. So, I think you did really great. And thank you for...
I really liked it also.
Pardon me?
I really liked it. I also liked that we discussed things.
Oh, good. I'm glad because it was really hard for me to just talk to my slides.
Oh, it was great. Thank you.
Able to...
I'm going to give you my, I'm going to just give you my Gmail. I'm not very good with my Alliance, okay? Because I'm kind of like, you know, just a part-time Alliant person. I just help Dr. Steinman out when she needs things. So my email is davis.alice.e@gmail. So give me a call, or I mean, not a call, but send me an email if you have any insights on Heather. Like I said, she's a work in progress. And I think there's lots of psychological things going on that she's not telling me. So, but anyway, give me some insights, and I wish you all could come and do some clinicals with me, but we have a blast.
You can invite us all to Hawaii. I'm sure some people might want to come.
Yeah.
I think we're all wishing we could come do clinicals with you.
Right. Yeah. So I enjoyed it, and I guess you're I think they scrambled all those the responses for those questions that I gave you. So I think they're all set back to where they should be.
Yeah, there's a setting where you can have the answers randomized in terms of the order that they show up, and I think somebody checked the box.
Yeah, so that's fine. But I think they're all back to where they should be. But basically, those are the kinds of questions that that I would expect that you to know, things in the physical exam. And just remember, if you're suspicious of anything, just check it out. You know, there's no right or wrong answers, you know, so if you're suspicious, like, oh, but you don't like the way they're talking to you, or you don't like that bruise on their arm, then check it out. but but that's the biggest thing, knowing normal and knowing abnormal. And if you hear something abnormal, go after it and send them back to their PCP. Okay, because that's how we work. That's how we have to work interdisciplinary stuff. I don't know everything as the PCP, so I'm going to go to you, and you're going to go to the neurologist or the psychiatrist or whatever. But that's how we can manage patients, and it's not always fragmented, especially if the PCP gets all the information. Do you see what I'm saying? Because then we can orchestrate it a little bit better. Because I can do some inquiries to the neurologist or the endocrinologist and that kind of thing. All right. So just don't be over anxious about your physical exam, but just do it based on your suspicions. If you don't like something, just go for it.
A side question, what about the status of prescriptive authority for psychologists in Hawaii? I know there's been a lot of resistance to it out there.
Well, they're working on it, okay? And Dr. Steinman is the person to ask on that, because she knows a lot about it.
I know it's okay in Guam, but I know they're still working on getting it there.
Right. Well, it's going up in the ledge this session again. It's been up a couple times. So it's got no, then it got a yes, but the yes was so unrealistic that it would never happen. So they are bringing it up again. So I think it's just a matter of time. And, for you guys, you're like us, the nurse practitioners, we didn't have prescriptive authority in every state. We fought for it. And, the MDs were the ones who said, no, they can't do it. They're not qualified. And, what NPs have determined is that we deliver very, very safe, quality, inexpensive care. And patients like us, and, we do a good job. Do we know everything? No, that's why we refer to specialists. I'm not a cardiologist, but, I can read an EKG and say, or I can listen and say, this doesn't look right. And then I want to get more information, right? But here's the other thing that I do. I don't ever just refer without giving my consultant some data, okay? So I would always get the MRI of the brain before I sent them to the neurologist. Do you understand? Did I lose everybody?
Yes.
No, we're here.
Okay.
I always
So
have a mood in the meantime. Otherwise, there's so much noise.
okay, so just so you know that do some homework before you get the consultant involved. Like do your labs, give them some work, your index of suspicion. Give them a good note. This is why I'm concerned about this. These are some labs. These are some diagnostic tests I've already done, or these are the things I would suggest. And that gives you a higher. When the consultant looks at you, they go, "Oh wow, this person's on the ball," rather than "Holy moly, they want me to do all the work." So that's another pearl. I always make sure I get a echo and a stress test before I send them to cardiology, unless it's an urgent cardiology referral.
Quick question. Are we doing a post-test after today?
No, Aiden, I think it's tomorrow, right? So I don't know.
Post-test, Dr. Steinman asked me to open it after the session. I'm going to be staying open until Monday morning.
Oh, is that good?
Yeah.
It's not hard.
Thank you.
Okay, well, enjoy your day.
Thank you so much. Have a good evening.
Listening.
Bye.
Thank you.
Bye. Adios. Aloha.